Welcome to Making Therapy Better, the podcast that brings together some of the top minds in psychotherapy as well as everyday clinicians to talk about where the field is headed and how we can achieve better mental health care for everyone. Making Therapy Better is hosted by Professor Bruce Wampold, who has dedicated his career to understanding how therapy works and advocating evidence-based methods for improving outcomes. His guests today are Barrett Griffith, Maureen Hart, and Geoff Gray. Barrett Griffith is CEO of CarePaths, where he has served for over 5 years, previously as a developer and then as CTO. He has 2 decades of experience in the tech industry, including healthcare IT. Maureen Hart, PhD, and Geoff Gray, PhD, are both psychologists with years of clinical and managerial experience who saw the potential for technology to improve the quality of mental health care. Together, they started CarePaths over 20 years ago as an electronic health record system, which now includes practice management and outcomes measurement tools. In 2022, they teamed up with Professor Wampold to launch Making Therapy Better, an educational initiative including a blog, webinar, and this podcast, coinciding with the release of Automated Measurement-Based Care by Bruce Wampold, PhD. Their hope is to improve mental health outcomes by providing therapists with reliable information on the benefits and practice of MBC, as well as effective and affordable tools for implementing it. As always, you can visit carepaths.com to start a free 30-day trial. And now, without further ado, Episode 12 of Making Therapy Better, Technology and Mental Health Care, with Barrett Griffith, Maureen Hart, and Geoff Gray.
Well, welcome to the final podcast of Season 1. We thought it would be a great idea to have a discussion with the principals of CarePaths, who sponsored this series of podcasts. For me personally, it's been a great opportunity to talk to leaders in the field, have a conversation about pressing issues, and to hear what they had to say about the research in psychotherapy and the practice of psychotherapy. So I have worked with CarePaths, who sponsored this series of podcasts, for several years, or several times over the years. And what I've been struck with is the dedication to improving the quality of care. I like to say, I'll only work with different private entities if they meet 3 criteria. One is they're addressing a need in the field. 2, they're based on what we know about psychotherapy, the science of psychotherapy. And 3, they collect data to actually verify that what they're doing works. So CarePaths, in the broad stroke, is a comprehensive mental health electronic health record company. I'm going to let Maureen and Geoff describe more fully what that is. So today, I'm going to introduce the founders and management of CarePaths. And then after these introductions, we'll talk just a bit about what we learned from the podcast. There were certain themes that came out that I think are worth discussing. So let's get started with Maureen Hart and Geoff Gray, who are the founders of CarePaths. If you would tell a little bit about how you got into the field, and more particularly how you were motivated to start CarePaths, and a little bit about the company to get us going. So I'll turn it over to you.
Okay, let me say a few things. Maureen and I are older psychologists. We came up in the age of managed care, and both of us worked for managed care companies in the 80s. And out of that experience, we realized that managed care was failing patients, that there was something fundamentally wrong with managed care, and it had to do with the fact that it was entirely profit-driven. I was a manager of a large managed care entity for a while, and the only bonus I would get was for profit, was for lowering utilization. And what I was concerned about was making fair allocations of care, determining whether care was working, whether people were receiving good value. And so I got into the outcomes business, and I met Maureen along the way. And I got into that after the managed care business because I figured that outcomes would really solve the problem. Well, after about 7 or 8 years with no customers, I figured out that wasn't going to work. And then we got into the EHR business. And so in 2000, when the internet revolution was starting, we started a EHR company, internet-based. Maureen?
Well, I also had been in managed care and stayed a little longer than Geoff did. And I think I had a more nuanced impression of it. I thought it brought some real benefits to the field for a while. Prior to my getting involved in managed care, I've been watching the for-profit inpatient facilities kind of boom. And I thought that was doing more harm than good because I was working especially with adolescents at that time. And it seemed to me every adolescent I saw who had been in an inpatient setting had learned something about how to be a better psychiatric patient. And things like cutting and cutting themselves and other things like that. But I think the managed care model is fundamentally flawed, as Geoff said. While I was still on the managed care side, actually kind of working for an insurance company, I helped set up a behavioral health system for a hospital that wanted to manage their own psychiatric care for their employees. And I was one of Geoff's first customers with the outcomes product.
And only customer.
But after that, I ended up moving further along and joining Geoff in the outcomes business, and then moving on into the electronic health record. I became a programmer for about 10 years, among other things. When you have your own company and it's a small company, you kind of get to learn how to do everything.
Great. So you're really inspired, again, to pick up on this theme of trying to improve the quality of care. I mean, the project we're working on together, Making Therapy Better, is really dedicated to this idea. I mean, the idea is that you have a network of clinicians who use your system, and we want to develop processes that are going to actually improve outcomes. So exciting. So why don't you guys introduce Barrett, and then we'll get all three of you involved here.
Barrett is a CEO. He is an IT guy by trade, graduated from Northwestern, and he's been with us for, I think, 5 years.
5 years.
5 years now, and he is immersed himself in the behavioral health care business, and is really an advocate for it. And he's done a great job. We'll let Barrett speak for himself.
Well, thank you. The more that I work with therapists and learn about what drives them and makes them good therapists, I realized, we kind of share a few common traits. It's the curiosity. It's the sense of holding us high standards of ethics, being able to listen and hear problems and hear the problems our customers are having, being able to solve problems for customers similar to the way that therapists are ready to solve problems for their clients, and to really, enable and help them transform their business and empower clients. So those are some of the things that I feel like I have in common with therapists and can advocate for them in this field. And I also wanted to, thank you, Bruce and Geoff and Maureen. The work that you have contributed in your careers to the field is extraordinary. Bruce and Geoff and Maureen, I feel that you really bring the original digital innovators to mental health, the original pioneers of digital mental health. You were in the space, decades before what we're seeing happening today. So I really want to thank you for your dedication to quality. Also, I want to thank all of the guests that we've had on the podcast, and the viewers, the listeners, for the comments and the opinions that have been added to the discussions, and for the producer of the podcast and editor, Dennis Hart. For me, making therapy better has been about collaboration. It's bringing these ideas and opinions that have helped me, as someone who's not doesn't have a strong clinical background or experience, get a sense of the challenges involved in delivering behavioral health services. And what I learned is that every case is different. Every mental health professional is unique, that there's really no single method or tool that is going to work in every case. So we have to collaborate, and we have to work together. So the guests that have been able to individually share their stories and speak to the importance of how they've been able to collaborate over the years, really, I feel, is a common theme that they use as they are looking to address their clients' needs. I feel like we also get a sense during this podcast series to get a historical sense of what's happened in the field and understand why things are the way they are today, why things, what happened during the managed care period, understand as well, what we're able to do and change in the future. And overall, just it's been a chance to have some fun, to learn what leaders in the field are thinking about when they're not thinking about their patients, or in our case, their EHRs, and to really hopefully provide a good experience to the listeners, to provide some interesting perspectives that can help us, has definitely for me been very transformative in my professional journey into mental health. So I wanted to thank you.
Thanks, Barrett. I think the combination of kind of the mental health perspective along with the technical perspective is really important, because we've seen various enterprises that really don't succeed in improving quality of care because they're so enamored with the technology, or so enamored with the bottom line, trying to have a business enterprise rather than one that actually delivers quality services. So this is exciting. So let's, I did want to mention, you said curiosity, and we think back to the interview with Bill Miller and Terry Moyers, and that's one of the key characteristics of effective therapists that they talk about is curiosity, a genuine curiosity in discovering what the situation is, and to really understand it at a deep level. And I get that sense from you, Barrett. So this is really right in line with what we've talked about. So let's summarize what we've learned from the podcast, or what some of the issues are. And I wrote down some of the themes. One issue, and which is central to what we're doing, is this idea of measurement-based care. It was central to Scott Miller, Jamie Delgadillo, and Michael Barkham, Robbie Babin's Wagner at the Calgary Counseling Center, as well as almost all of the other guests, talked about the importance of actually understanding patient progress by measuring various aspects of the therapy endeavor. So I'll just talk for a minute about what I learned here. Measurement-based care is the first initiative we took in making therapy better project. And what was clear for me in these discussions is that we should be doing a comprehensive measurement, not only symptoms. Many of the systems focus almost exclusively on symptoms, but also other psychological aspects of functioning. Well-being, for instance. We know loneliness is absolutely critical to mental health, but also physical health. And then, of course, the process of psychotherapy. And that was mentioned by several of the guests. So comments about what you took away from the discussions of measurement-based care? Other than, go ahead, Geoff.
Go ahead.
Well, I thought it was a fascinating discussion. One thing we didn't talk about is the fact that it's not done. It's a great idea. I mean, the data supports it. It cuts down on no-shows and patients at risk for a bad outcome. And I suspect, Bruce, that with your algorithm and your system, that the benefits of measurement-based care are much greater than what's been achieved so far in the studies that, at least that I've read. Would you agree with that? Do you think that measurement-based care has potential? We know that. Do you think it has greater potential than we've seen?
Well, I think you hit on the major aspect of this, that it's clear, and I think all of the guests, with some exceptions, would agree with this, that it's really necessary to understand how therapy is working and to make adjustments to work better. Now, we know so many therapists in practice don't use measurement-based care. And there's some structural reasons for that. But I think we need to do a better job of disseminating systems that actually work for the therapist. They're not burdensome, they're easy to implement, and they provide really important, actionable information. I mean, John Norcross, measurement-based care is not his primary interest, but in his private practice, he says with some exceptions, he uses this with every patient because it's really helpful to improving quality, just as you said. So that's part of it. The second part is, even in those agencies that use measurement-based care, it's often implemented in ways that let's put it this way, that aren't optimally effective. It really, the climate of the agency, the way in which the systems are used are absolutely critical. So there's a lot of aspects to this. But if I were asked what's the one most important, more easily implemented aspect of care, measurement-based care would be that.
Bruce, one thing you didn't mention in the measurement-based care protocol is the fact that we also monitor for side effects, adherence, and compliance. And, so many, 40% or more of patients therapists are seeing are on medications. They don't see the PCP is doing 80% of the prescribing. They don't see the PCP very often. This is very, very valuable information that is really integrated care that can be shared with the PCP. And I think it's another beneficial aspect. I think measurement-based care really fits very well with the integrated care paradigm. And I think that's going to have, and I think one of the drivers of measurement-based care going forward is the fact that payment systems are going to integrate that. Already there are some codes now but not for psychologists, but there are remote therapeutic monitoring codes which allow for monitoring for adherence and for treatment. And I think this is a coming thing. So I think this is going to be part of the driver, but there still has been a lack of traction, I think, with clinicians. We have to do a better job with that.
Yeah. Well, you brought up this idea of integrative care, and I think that's Ed Jones' discussion was centered on that. But this idea of monitoring not only the psychological side of this, but the medication side as well, with split care or integrated care, absolutely critical. I mean, we know that most people on psychotropic medications rarely see the prescriber. So it's really important that that information be available to the prescriber. Is the patient taking their medication? And are there side effects that are interfering with functioning? And those two things are absolutely critical. I think that what's important is that as measurement-based care becomes more, mandated, but incentivized in different systems of care, that we really do it right and we use this information to make therapy better.
Yeah, and Bruce, to pick up on that, do it right. I was interested in outcomes 30 years ago and thought it was the answer. But I also realized that there was no practical way to collect data from clinicians. And it's only been with the internet, and it's only been with the ubiquity of smartphones that you can automate measurement-based care, because frankly, clinicians are going to, it's empty compliance is what you get for the most part. They just say, here's a piece of paper, please fill it out. You go to the PCP, they give you the PHQ-9, you answer it, but it's not meaningful. It's not, and it has to be meaningful. It has to be integrated. And so anyway, I think that's the practicality, the implementability of a system so that it's a no-brainer and does not require a burden on the clinician or burden on the patient is absolutely critical. As a matter of fact, I would almost say that the technology was behind, that the science of outcomes was ahead of the technology. The technology has only caught up, and now that makes it really implementable. And that's a game changer.
Absolutely. I mean, we're old enough to remember when you got a paper and pencil form that you filled out before the session and after the session, and that information was only available to the therapist and to the patient sometime in the future. Now, in the system we've set up and many other systems, this is done on your smartphone. You get prompts during the week, so it's not just during the session proximity that you fill these out. Much better information than you had before. But the critical part is this integration, that it's part of therapy to look at this information, examine what the implications are for treatment, to know whether we're making adequate progress or not, whether the relationship and the belief in the treatment is adequate. I mean, it's just quite amazing that we can do therapy without this information. And people who have grown up doing it and learned it when they were in their training and have done it their entire careers couldn't imagine doing therapy without it. Now, we got to keep in mind it's one source of information. Interaction with the patient, of course, is important. But where there's discrepancies between your perception of how things are going and what the patient reports on the measurement-based care instruments is really important to understand. You know, the other thing that was apparent in the discussions, which is related to this, is the focus on therapist and therapist improvement. You know, we have so many discussions. I go to conferences, more and more people are talking about precision mental health. And we match the patient to the best kind of treatment, whether it's psychotherapy or some digital solution. And, you know, the evidence is pretty clear. That only gives maybe at best a marginal advantage. The matching is kind of silly in a sense, because often access is a problem. You don't have that many choices of therapists to choose from. So what's really critical, and was mentioned by several of the interviewees, is this idea that every therapist should be working to improve their outcomes. It's a craft. It's an incredibly complex craft. But with the feedback from measurement-based care and other efforts, therapists can improve. So when we think about, Scott Miller, Robbie Babbins Wagner, Helena Nissen-Lee on professional self-doubt, Catherine Eubanks talking about alliance and alliance rupture. The focus of all these discussions were on how therapists can actually improve their outcomes. So, comments from you guys about precision mental health care and about
the term itself. I mean, precision mental health. I mean, what is mental health treatment but precise? Every individual is different. I mean, they talk about precision medicine, and I understand that they're using averages, but by definition, psychology is precision. It seems to me. That's just a comment.
Well, I agree with you. We've been saying this from the beginning. Everyone's case conceptualization is different from everybody else's. How you came to be distressed and how that distress is maintained is different for every person. And getting to know the person more than the disorder has always been a priority of psychotherapy. So, but I think it's taken to a new level, Geoff, this idea that somehow we can measure something about the patient before therapy and match them with the most appropriate treatment given in a certain way.
Do you think marketing and managed care companies? I mean, the managed care companies, or the behavioral health companies, big ones, the unicorns. Some of them on their websites talk about their matching algorithms and the fact that they're able to provide better treatment because of their matching algorithms. Typically on these sites, there's no data about the matching algorithms. How sanguine are you about matching algorithms?
Well, again, let's suppose that matching is something that's worth pursuing. Ideally, something about your personality, your desire for therapy, your cultural and religious and spiritual practices indicate that there are some therapists that might be a better fit for you than others. Well, that's an ideal world. We have an access problem. We don't have enough therapists as it is. I don't see how you can say to a patient, we're going to get you the best match when there's only 3 therapists that have openings in your entire network. So we can't optimally match you. You'll be lucky if we can find somebody for you that you can see in the near future. Better to say, we want the therapists in the network all to improve so that every patient's going to have a better outcome than they would have had otherwise. To me, putting the focus on therapists and the therapist skill and development is a much richer source of improvement than it is to try to use this matching algorithm. And it really converges with this idea of measurement-based care, because you need some data on your outcomes in order to understand how you might improve.
One thing I like about the management care approach is that it puts the trust in the therapist. It doesn't try and prescribe to the therapist some new way of approaching patients or some new set of interventions. It gives them more information and relies on their judgment, their understanding of the patient, their understanding of themselves to use that information.
Yeah, I mean, we have to take the information from measurement-based care and use it for this particular case using our clinical judgment. It doesn't take away from the importance of clinical expertise in any way. It only provides additional information. So, Geoff, you asked a question and I had something in mind I forgot, and that is, in a lot of contexts where measurement-based care is part of systems of care or agencies, a lot of the therapists don't ever open the graphs. So they never look at this information. And to me, that's an indication that implementation, understanding of how measurement-based care might be useful has been insufficient. So Jamie and Michael talked a lot about implementation and the importance of getting therapists to really understand how important this information can be in treatment.
I'd like to chime in a little bit. CarePaths recently released a measurement-based care tool in 2022, about third quarter of 2022. So our initial group of providers who have been using it have started to give us feedback, and we've been able to understand, how well their patients are complying with it and how well their staff are complying with it. And what we're finding is that it's really surprising that the number of clients of theirs, their patients, that continue to do and complete the assessments beyond 3 weeks of treatment, and that continue beyond 6 weeks of treatment. So we're finding that the staff are finding it useful as well. They continue to have more patients participate in the assessments. So, even though we're not getting deep into their cases, we are hearing positive feedback.
Yeah, and Barrett, you bring up a really important point, and that is, it's not just the therapists who are interested in this information, but the patients benefit from seeing their progress. I mean, we've all worked with patients who come and say, I'm just not making progress. And then you look at your graphs, and when you discuss it with them, they see that they have made demonstrable progress. And that demonstration of the progress is just really clarifying about how their hard work in therapy has resulted in better outcomes. And of course, it works the other way around as well. So the information from these graphs is really important. And I'm happy to hear that the use of the system we all designed is catching on with the network. One of the other issues that I found really interesting was this idea of, to be an effective therapist, you really have to be skilled, aware, and involved in understanding context and culture. Jesse Owen talked directly about culture, but one of our more popular episodes was George Silbershands, who talked about context for every patient, whether they're kind of a member of the mainstream cultural aspects of society or not. That context is really important. And context has to do with, of course, culture and race and ethnicity, religion and spirituality, but also just the manner in which you were brought up, your family attachments, the context in which you live, what you read and what you think about are all critical to designing optimal treatments for patients.
Bruce, I have I think a neat example of that. I was talking to Maureen last night about this. She worked for 13 years at Meharry Medical School, which is a Black medical school. She was a psychologist there, and she worked with, and why don't you tell the story about how the people interacted?
Well, I think there was much more a sense of community in that organization and that staff than I've ever seen anywhere else that I worked. And they treated the patients as community members. And it wasn't unusual to see therapists who weren't assigned to a patient stopped and talked to anybody they knew in the hallway. It was like a community gathering. And I think the patients really felt comfortable there. They kind of trusted the institution.
Using Betty, when they used the Betty? Go ahead.
I don't know what I said last night, but he wants me to talk about it.
It was, anyway, here's the gist of it is that the patient was the doctor was very familiar with the patient.
I know what you mean. Yes. There was a therapist who was calling up a patient, and she called her up and said, "Hello, Mrs. Smith. This is Betty." She kind of humbled herself in front of the person she was serving. And it was kind of at first I was jarred by it because it sounded too familiar or too.
I'm Dr. Hart.
Yeah.
You're down there, I'm up here.
But they just there's other people in the community who needed something and they were going to help them. They were neighbors.
Yeah, I think this is so important. We talk about the alliance between a patient and a therapist, but there's a very important alliance between the patient and the system of care. Are they treated with respect at the reception desk, in telephone calls? Is there respect for their suffering and their efforts to improve recognized and valued? So important. In fact, Christoph Plukicher and I just wrote an article about the alliance And we have an entire section about alliance with systems of care. And we forget that patients, not just interacting with us as therapists, but with other personnel, with the physical layout. Is this a place that's welcoming and attractive?
Is there a culture of humility? I mean, so frequently there's this implicit authoritarianism. Well, Bruce Wampold, you're the top of the heap. You're the professor. The patient's the bottom of the heap. The trainee is in the middle of the heap. The therapist is kind of 3/4 up there. And I think that implicit authority, patients have a lot of skills. They have a lot of intelligence. They have brilliance, much more than I do in many areas. And the messiness of life, the fact that this egalitarian notion, it seems to me, is very important. And I think that I've seen in the therapy world a little bit of this kind of an arrogance. And it's not, and that, I like that the humanistic element informs your thinking, Bruce. It informs, even though you're a scientist, it informs your thinking. And that makes it really, I think, relatable.
Well, Geoff, it's interesting because, we have this evidence-based treatment kind of movement. Everything in our society now is evidence-based treatment. But even in the most well-defined protocols has to be given with this humanistic attitude. These are people struggling in life. I mean, I'm in awe of patients and what they've survived in their lives and are making an effort to get better. And we have to honor that, regardless if you're the most strict cognitive behavioral therapist. We have to remember that aspect of care. I'm working with Jerome Frank's daughter to revise Persuasion and Healing and to reread Jerome Frank's observations about treatment. I mean, he was psychiatrist trained in science, but he saw through to what the core importance of what we do. And we can't forget that. And this is also what bothers me a little bit about the precision mental health. We're making it an algorithm rather than a humanistic practice.
We're forgetting what Jerome Frank taught. There's an erosion now. The digitization, the celebration of digital solutions, and without the sidelining of the human in psychotherapy, I think is a wrong turn. I think a lot of these digital applications, I mean, the way I see a digital application, it's a relationship with another human being should be an I-thou relationship. It should be a one-to-one relationship. Seems to me a relationship with a robot or a machine is an I-it relationship.
Yeah,
there's no person there. And I think that people have interpersonal problems. They don't have problems with, and I don't think that using that kind of I-it approach is ultimately what is curative. I mean, I think that's a cliche, but there it is.
Well, it's an interesting idea, and we should talk a little bit about. I mean, we talked to Don Norcross about this in the interview about digital solutions, well, some of the others. But, he's an expert on the efficacy of self-help support groups and so forth. And there are people who do change for positive ways in their life through reading books or digital apps, and more power to them. I think there's lots of ways we change. But as you say, many people, the whole core of their difficulties is relating to other human beings. And psychotherapy is so powerful in that way. And everything has become depersonalized in our world in multiple ways. Psychotherapy has a very personal change through that relationship. And we have to continue to value that.
That's interesting, Bruce. So, as you mentioned, there are societal changes that's happening, but for therapy, it's the humanistic aspect of it that's going to continue to make it work, regardless of what happens.
Yes. I mean, it's a rare opportunity, isn't it? To talk to another human being who has the training and skill to help you, but is willing to meet you as another human being and use that expertise to help you overcome difficulties. What a privilege that is. What are other things? I'm trying to look at my notes here of things that I took away from our discussions with various experts. It was a real honor for me to have the opportunity, and I thank you guys for sponsoring this to talk to
Well,
these people.
it was a very good, I think, look at the lay of the land, the state of play, what's going on, what's innovative. And, well, for me, it was quite illuminating because I don't read the literature very much anymore.
What was interesting, and partly this is due to the people we picked to be in the first season, but there was very little discussion about which treatment is the best, okay? The focus was on other ways that we might improve the quality of care, other than you should do it in the way that I see best. Probably Jonathan Shedler would be one who clearly made the case that long-term therapy was needed to achieve desired outcomes, which is debatable. And certainly from the comments that we've received, it is debatable. But for the most part, the focus was on aspects of care other than the treatment being delivered. And I found that refreshing. Well, for the listeners, we really would like to hear from you about topics and people you would like to hear from in season 2. So as we go to the planning stage of doing the next season, let us know what you would like to hear us discuss and who you would like to hear from. So there are other comments we should make before we wind up season 1?
Well, it was a great privilege for us to work with you on this, and to help us with the measurement-based care algorithm. And it's very exciting, I think, what we're embarked on. And I think it has a real opportunity to make a difference in the field. So for me, speaking personally, it was an absolute delight.
And I'd like to second that. I kind of regret that I'm not doing therapy anymore when I hear so many good ideas and think of what it would have been like had I had a measurement-based care system to give me that kind of feedback. It looks very attractive.
Yeah, it's interesting, Maureen. In some ways, we've made a lot of progress from when we first entered the field. And in other ways, we're doing things pretty much the same. I think that's one topic we should do is, are we making progress? And are we improving as a field? Would be fascinating to do. I encourage everyone to go to Making Therapy Better page and find out what we're up to. And there's links to useful information and description of our efforts.
I encourage our listeners to subscribe if you can, so you can hear about our new episodes when they're released in the new upcoming season. Thank you, Bruce.
Well, thank you all for the opportunity. Been great.
Terrific. Thanks so much.
Thanks.
Thanks for listening. That's all for the first season of Making Therapy Better. If you haven't already heard them, there are 11 previous episodes to check out. And if you find them interesting, whatever platform you're using, please subscribe, leave a review, or share them with your network. Stay tuned for the second season later this year, and reach out to us on social media to let us know who you'd like to see interviewed and what topics you'd like to hear discussed. Links are in the show notes and video description. Making Therapy Better is brought to you by CarePaths. CarePaths offers a complete behavioral health EHR and practice management software solution, including claims, billing, clinical notes and documents, scheduling, and teletherapy, all for one simple and affordable monthly price. CarePaths EHR is HIPAA compliant and ONC certified, and can also support electronic prescribing for an additional fee. Their latest release, CarePaths Connect, includes automated measurement-based care and the ability to create a digital front door for your practice, as well as a free mobile app designed to increase patient engagement. If you're just starting your practice or are dissatisfied with your current EHR, go to carepaths.com to start your free trial today. To find out more about Bruce Wampold and his work as CarePaths Chief Clinical Officer, visit makingtherapybetter.com.